Thanks for the invitation. I'll try to keep this sort of generally relevant, but certainly the reverse shoulder arthroplasty is the arthroplasty of the moment, really, in upper limb surgery, and it certainly gets a lot of discussion at meetings. Declarations, no personal interests, unfortunately. We do get institutional support from the companies, and we're involved in an arthroplasty trial, but not in a reverse prosthesis. Now, the background, why reverse? Why this move to distort and change and alter the anatomy? Well, it was born really out of the first ever shoulder arthroplasty in the 1890s by Payen was a reverse arthroplasty. I think it survived a matter of days, if not weeks, and that was about it. But reverse arthroplasty is to try and contain and make the shoulder joint, which is intrinsically unstable, more stable. The early attempts to do this in the 70s were met with almost universal disaster and loosening because of the way it was trying to link a large lever to a very small amount of bone on the scapula. Grammont in the early 90s came up with his early design here on the left, or in fact, it wasn't his first design, his modified design. And that certainly he was French, it was sort of the birth, if you like, of an explosion of interest in this in France and a reinvention of it and the uptake of interest more recently since the FDA have allowed its use in America. And this was the first attempt by Pan to, by Grammont to come up with a reverse prosthesis. It was a polyethylene stem on a cemented spherical socket trying to fix that to the glenoid. Not surprisingly, that didn't go very far. So what are the advantages? Well, it's all about changing the biomechanics, particularly when you've got rotator cuff deficiency and you don't have that containment, as Frank really nicely pointed out, with massive tears. You lose that containment of the head and you lose its containment of the centre of rotation. So what we do in a reverse prosthesis, we see a medialisation of the centre of rotation. So this is the biomechanics 101. And therefore you increase the lever arm of deltoid, so you improve deltoid efficiency, and you also get an alteration of the joint reaction force. So this has been looked at and also published recently in cadavers in a project out of Melbourne that Martin Richardson was involved in on the edge of. And so the mechanics of it actually work, but you do definitely get different shearing loads on the scapula. So when you lengthen deltoid, you get another thing that happens. So you're bringing the joint line down, as you can see. You actually increase tension in deltoid, improve preload, and you therefore improve the function. If you go back to your basic physiology, improving muscle preload improves function, improves work output of that muscle, and it becomes a more efficient lever arm. But there may be a cost for that down the track, and I'll come to that later. The other thing that happens is in medialising deltoid, Kapanji has described 7 parts to deltoid. If you medialise it, you take the centre of rotation medially, and you're actually able to recruit more deltoid in cross-section. So you've actually improved its lever arm, and you've got more muscle actually being able to act on that lever, remembering that it's contained against the scapula because of the reverse geometry. So what has been evolved as the indications, and we'll get to this first and then we'll get to it last, and I think this is sort of the real essence of why we do reverses. The most common and certainly the primary in Grammont's initial indication was for rotator cuff tear arthropathy, the scenario when you get arthropathy at the end of a cuff deficient shoulder. It has, however, been used in failed hemiarthroplasties, particularly when that's been associated with rotator cuff pathology and tears. Pseudoparalysis, in other words, inability to lift the arm above the horizontal in that setting, so particularly when there's maybe less arthropathy and more weakness, such as in the massive tears. After tumour resections, where for the same reason you get up with a cuff-deficient shoulder, and you have to do a proximal humeral replacement, certainly been done, not in any large numbers, and certainly not reported in anything that you could really analyse, just more case series. It has been more recently advocated in the older patient with the 4-part unreconstructible shoulder. Why? Well, to get away from the dilemma that you have about trying to restore tuberosities and then running the gauntlet of those tuberosities healing when quite often they don't. In fact, after a third and in some series half the time they don't heal, no tuberosities, no shoulder function. And then in the same when you've had malunion or malpositioning of those. So really, it's still, and this is from another paper, it's been still most widely reported for cuff tear arthropathies. And I think when you analyse the literature on this, you have to look at what the indications were for surgery when you look at the reports, because most series still report group most of the patients together. Certainly the early reports do. And it's been proven, and the outcomes are pretty well understood now for cuff arthropathy, but in the other indications, they're far from clear. So when shouldn't we use it? Well, it's certainly argued by many that if you've got an intact tuberosity relationship, an intact cuff, irrespective of the primary glenoid pathology, you shouldn't use it. So if you've got intact cuff, intact tuberosity to humeral head relationship, don't do it. If you've got a deficient deltoid, because this prosthesis relies, or this geometry relies so much on the deltoid for function, shouldn't do it. Obviously, infection, now that's a little bit controversial, but certainly the infection rates are higher in reverse across the board, and I'll come to that, and the reinfection rates are therefore higher. And then the other controversial one is age. The initial indications and the initial studies out of Europe, the average age of the patients is very close to 70. So when you get under 65, because of the unknown long-term outcomes, it's not recommended. And I won't go through all these results, but other than to say that if you look at several groups, when you've got E2 glenoids where you've got a lot of medial and superior wear, the results look good. If you compare it to hemiarthroplasty for the same age groups, the scores for the same disease indication are better and have been shown to be marginally higher in reverse than hemiarthroplasty. And one of the things that often gets spoken about, and I'll come to, is complication rates. And if you take all complication rates, not just revision as an endpoint, then reverse complication rates probably are approaching, or hemiarthroplasty, I should say, is probably approaching the same. But you do need to have some tissue intact to get good function. If you look at endpoints other than revision, in other words, clinical outcome, you need to have some balance of tissue, particularly teres, or you'll get a functional deficit, particularly in external rotation. So trying to maintain some balance front and back, rotational force couple between subscapularis and teres is important if you want to have a happy patient at the end of it. So that needs to be assessed, and sometimes it means even if it's an arthropathic patient, you may need to use MRI to see what you need to do. If you're looking at outcomes, and then you look at the far right here, you look at the revision rates, you can see there's wide variance in what the reported revision rates are, anywhere from 4% in Savo's series right up to 33% in Werner. And Werner's series is one of the earlier ones published, and they had universally more complications than everything that they did. And often, I think that was also their early experience, so I think it actually is worth sometimes pulling that series out of the literature and then looking at the averages with that one excluded. But if you're looking at outcomes, high satisfaction rates, high pain relief rates, the constant scores, remember this is constant score, remembering it's out of 100, where 100 is the highest score possible in a normal shoulder. You've got to remember that in age, as we all degenerate, our top end constant score, our shoulder function actually deteriorates with it. So there's about a 10% per decade deterioration in your constant score. So constant scores in the 60s are not stratospherically good, but they're not terrible, and they're certainly better than the natural history scores for cuff arthropathy. And hence, this is one of the dilemmas we have, is that you really can improve their function. So we've got this quandary. You know, we've got an implant, we've got a prosthesis, we have a range of products where you can get excellent pain relief, excellent function, where there hasn't been great treatment options in the past other than the debridement sort of options we heard Frank talk about. So when it's used as designed for the designed indications in patients over than 70, you can actually get some of your happiest patients out of that, and they're certainly amongst my happiest arthroplasty patients. But if you start pushing the margins, you may end up regretting it. So therefore, where's the problem? Well, extrapolating outcomes for indications that haven't been reported or not understood, I think that's one of the issues. You get this indication creep where you start to feel confident and familiar with this prosthesis. You start to apply it to other things like chronic instability, large amounts of bone loss, and I'll show you an example of that. And not insignificantly, you're also burning bridges. You're burning cuff tissue, you're burning bone tissue. So your bailout options, once this goes wrong, are actually not very good. You end up with essentially a flail shoulder. And because you don't really have much glenoid bone stock, it's not a pelvis, the scapula. you really have only got one good shot at it, and then after that, particularly with the reverse, you've really got much else to use. So I think that's something to be borne in mind. What are the complications? Well, I won't go through all of them, but other to point out that most of them will be familiar to anybody who does arthroplasty surgery. The complications are not all totally different, but there are some ones that are unique to reverse arthroplasty, such as metaglean migration. That's the medial component on the scapula. Loosening and migration of that, that's definitely well reported. And as I said, it does. You generally do end up with taking quite a modest amount of bone stock away when you put one in. Erosion, inferior erosion, will come to that. That's unique to reverse. Stress fractures, that's generally not seen in standard shoulder arthroplasty around the scapula. And this is the concern, although there's very little literature on it, and this is late deltoid failure. So we're talking about 6 or 7 years down the track when you get deltoid failure and pain. And there's very little literature on that. And also rotational weakness if you don't have those other force couples that I mentioned. And here's just, I guess, this is a summary of Werner's paper, but also compared to the other two big series, particularly Walsh's at the bottom, is another French centre from Lyon, very experienced, lots of experience with reverse. If you look at across that globally, out of all these patients, you're looking at it up to, if you measure all complications, up to 25%. I guess we have to ask ourselves, what's an acceptable complication rate for a complex pathology? Remembering that if you stick to the same initial indications, you're dealing with a pathology for which there were not good options before, other than the odd steroid injection, analgesia, occasionally a debridement and a pat on the back, and an unhappy patient. So it's worth bearing in mind. If you look at revision as an endpoint, you're probably looking more at around the 10 to 12%. And so let's look at some of these individual complications. Firstly, infection. Why are the infection rates higher? I can tell you for a standard arthroplasty around the shoulder, infection, revision on the joint registry for infection is around 1%. Okay, it's higher than for hips, but it's around 1%. So for reverses, it's anywhere from 2 to 7 times that. So it is high. Early reports are up to 15%, even 20% in one series. Why? Well, you've got a bigger dead space for starters, and you're unable to close the joint. You do not have that cuff left that you can actually contain a hematoma. And a lot of these patients are thin, elderly, with very atrophic muscle and small deltoids, and it's very hard to seal that off from exterior. So that may be a risk factor. This is an example of yours truly, and this is an infection that occurred 2 years after implantation in an insulin-dependent diabetic who also had, you can see, developed a stress fracture of his acromion, but that was managed not operatively and settled down. But interestingly, this is actually, and he's been on long-term suppression, this gent, and this is now 8 years. This is his recent photo, picture, 8 years down the track, and his glenoid has looked like that for the last 5 years. So on suppression, it's been maintained, but it's certainly a worry, and he's had no reactivation, but he remains on chronic long-term oral antibiotic suppression. So instability, next issue. You don't have that balancing, you don't have that head suppression of the suppression and containment by the cuff. So you're really dependent solely on length-tension relationship and compression of the force couple being contained by the upward pull of deltoid against this. And if you get the front and back balance of that incorrect, you're going to end up with a risk of instability. And this is more a risk when you lose that myoperiosteal sleeve of the proximal humerus. So if you've got bone loss, the risk of this goes up. And this is an example. And obviously this is a severe shoulder. You don't have really many options for this in a patient in their mid to late 60s. It's almost like a Gorham's disease. You've almost had proximal humeral resorption. But to get that length right, you've got no soft tissue containment around here, a very large polyspacer, and not surprising, I guess in retrospect, an unhappy outcome and a recurrently unstable shoulder. But a patient who can function and doesn't have pain, but still a complication. So prosthesis dissociation. Now that's something we didn't see a lot with early shoulder arthroplasty, but it's certainly been reported and increasingly reported with reverse arthroplasty, and that is the uncoupling of the components. And this is a risk factor in any arthroplasty where you've got high modularity. And again, the registry tells us across the board, hips, knees, whatever, you increase the modularity and you're basically increasing modes of failure. So your revision rates are going to go up, and that's certainly been seen, and it's reported anywhere as 0.2, but up to 3%. And these are catastrophic failures, and certainly in reverses they're seen, and I'll show you some of our data, but they generally are seen and occur early. And yet sometimes it can follow on from a very minor tweaking of a component that changes its behaviour. Now, I've mentioned this. I can't really tell you much more about it other than that it happens, and it tends to happen around 7 or 8 weeks, and it's unexplained. We don't know, other than it's probably due to long-term muscle overload, and you get a failure of the deltoid, becomes weak and sore. Loosening, this is another component of notching, and that's inferior notching is something that is particularly unique to the reverse arthroplasty. The glenoid remains the weak link, and the initial fixation is crucial. So particularly for these HA-coated prostheses on the scapula, there probably is an argument for really being careful with how much load you put through it and not doing any resistance work early, and perhaps even limiting your range of motion in those first 6 weeks to make sure you get a very stable base plate so that you get that initial fixation and initial stability. And this is the grading of notching according to Neuro, and it's certainly been described in many series. One of the unknowns is, though, you can actually see quite severe notching, but it's not necessarily, the correlation with failure of the implant has not been really well correlated. So it's something we're observing. It's certainly a concern when your bone stock is melting away on the inferior aspect of the glenoid and undermining your base plate. It's a great concern. So it's a combination of impingement and osteolysis, and I'll show you that. And this is just the incidence. In grade 4 is not insignificant in this Severo's series. Nearly half his patients had notching right up to that inferior screw and just beyond. This is a study that we're doing at Deakin and looking at the finite element analysis for the Department of Engineering, and it actually, the model that we've developed predicts very well where this notching is going to occur, and our interest in this is to see how, if we start moving the base plate and the glenoid around, can we avoid it or can we make it worse, and can we change the force couple to get rid of that red zone, or at least reduce the red zone. And work on that will continue to see if we can change, by changing positions, where we can make it better or make it worse. And you can see on this slide that there's certainly quite a lot of medial notching, and you get polywear, and we know polywear will lead to osteolysis, and the shoulder's no different. These spine and acromial fractures are about 1 to 3%. Fortunately, nearly all these generally can be managed non-operatively, so they recover, but it does mean a period of diminished function for about 6, 8, 12 weeks for the patient. Have to unload it, even give them the sling for 3 or 4 weeks to allow an initial healing, and they usually settle down. But again, it just highlights how much overload there is of this deltoid. You're making it work a lot harder than it normally does, increasing the force through the spine. So we go, just to finish off, we'll just quickly zip through some of the registry data which we've been involved in, which is starting to lead to some interesting insights into this. First of all, if you look across the classes, the revision rates around Australia are not actually much higher than they are for conventional shoulders, 2.22 to 2.35. So that in itself is interesting, a bit of a surprise. If we go back a year, so the graphs are merging. If you go back to the report before, there was a bit more, not a significant difference, but there was a bigger difference, but the graphs are merging. We look at reverses in particular, and you can see that there is definitely a higher failure early, and I think this is these prosthesis dissociations, glenoid failures, loosenings of that metaglean. And that's why I think that initial fixation is crucial. But if you come out to a year, the graphs are essentially the same, and you can see over the following 3 years, the graphs are following. Now, what happens out to the right, we can't say yet, but obviously we watch that with interest. If you look at different pathologies, there is nearly a significant trend for higher revision rates with fractures and dislocations. So watch this space. That's definitely something we're going to be looking at again in this year's report. But for other pathologies, they're tracking about the same. Interestingly, gender difference. Again, this is 0.07, so not quite at the level of 0.05 we set, but a trend that we'll need to watch. Also, the different prostheses, they don't all perform the same. And the early experience with the early SMR, shows they're certainly being revised more often. Now that we can't tell you why they're all being revised more often, but there's a higher revision rate. And other than to say that seems to be due to loosening and lysis on the glenoid side. Okay, so again, that's not a surprise. So in summary, these are what we know about revisions for reverse. Age is not a factor as yet. The gender may be a factor, don't know yet. We do know there's a peak in the first 3 months, so you need to warn your patients about this, and you need to make sure you get that initial fixation right. And certainly the prosthesis you use may be a factor. So in summary, reverse isn't a simple solution. There are complication risks. It's unforgiving, and there are limited salvage options. You need to know the prosthesis that you use. You need to train specifically in it. You need to be shown how to do it, and you need to do it preferably in cadavers before you start on people. And you need to know how to put in a glenoid. If this is going to succeed, you need to be able to get a well-fixed glenoid. So to do that, you need to be able to see the glenoid. You can't put in a glenoid if you can't see it. So you need to be experienced with exposure of the glenoid. And you need to choose your indications and patients very carefully. And remember that increasing modularity sometimes helps the surgeon, but doesn't always help the patient. And just a little plea to please make sure for whatever joint you put in, upper or lower limb, that you check your own forms and check the diagnosis on it, because what we remember, data in, data is quality out. So if you make sure that the diagnosis codes are accurate, we'd appreciate it. So be careful with the glenoids that are destroyed, got a lot of bony destruction. Be careful where there's osteoporosis. Don't consider reverse if there's a deficient deltoid, and lots of caution in the younger patient. Really, it hasn't been proven in the literature for younger patients. Certainly acknowledge some of the engineers at Deakin and the registry staff. Thank you very much.